welcome everybody, and thanks for taking the time out of your busy schedules to attend this webinar. It's my absolute pleasure to be able to give a talk for Eaglet about the E.S.P and my just my experience with it so far. And it really has been a piece of technology that I would use every day in practice. And yeah, I mean, I would be lost without it. So a brief introduction about my initial journey. So I was first introduced to scleral lenses my final year in college when I was doing my degree. So I had the opportunity to spend 6 months at the University of Houston College of Optometry, and that's where I first started fitting scleral lenses, and I was just absolutely amazed at the difference it would make to patients. And you know, people saying, wow, they could see again. And this was definitely a part of optometry that I wanted to get more involved in. So when I came back from Houston, I qualified, and then I started working in practice, and I started fitting scleral lenses by myself, I suppose. And it was extremely frustrating, I suppose, it was my sentiment at the time. An awful lot of chair time, trial and error, putting multiple lenses on eyes and not getting good fits, and trying to think, you know, why is this happening to me? Am I that bad? And it was that stage then that I started looking at technology around scleral lenses and scleral lens fitting. And so it was Google searches, and I was going through lots of searches, and then eventually I came across the E.S.P, and then I got talking to Arnu, which was great. But I suppose one of the things as well that was very important from my own point of view when we were doing this was that the danger of the breakdown in the trust between me, the practitioner, and my patients. You're putting multiple lenses on eyes, and eventually they're kind of going, well, you know, do they actually know what they're doing? So the E.S.P was a huge help there, and it gives you confidence. But in optometry, there's so much involved in terms of technology for all of the aspects, OCT, topography, etc. So, you know, why not do it for scleral lenses? So this is a brief outline. I'm sure you're all quite familiar with this, but this was like a big light bulb moment for me when these came out, and looking at the E.S.P going, okay, so this is why all my lenses are down here as opposed to centered on the eye. So muscle insertion, it really makes a difference. To sum up this slide, it's essentially saying that the further you are away from the limbus, the more irregular the scleral shape is, and also there's a propensity for the nasal aspect to be a lot higher or flatter compared to your temporal and inferior aspect of the sclera. This is the study, and there's a brief summary of the main points of it. But one slide that really sums things up for me is this one here, okay? And this is done on normalized, but you can see here the difference between the nasal and the temporal values here, okay? So a huge difference between the eyes, and we can see that it gets greater between nasal and temporal. So they're looking at sags at all these different chord lengths, 13, 15, and 17 millimeter chords. So you can see here, the further that you go away from the limbus, the greater the irregularity or the difference. So here is my first case. I'm going to present 3 cases, or discuss 3 cases to give you a bit of an idea of my experience, or what I would use it for, use the E.S.P for. So the first one is a 33-year-old male he presented the clinic, the history of contact lens wear, and he slept in his soft lenses once, and he got a Pseudomonas infection. So he had a really deep stromal haze after the infection, and he had been told that a penetrating keratoplasty, so PKP, was the only solution to have him seeing well again. He really was not keen on that option, and so he ended up in our clinic, and he said, "What can we do?" This is a good example, I suppose, of a co-management approach. So I work in a refractive surgery clinic. So the first step was he had transepithelial PRK done to reduce the amount of haze that was in the cornea. And then the surgeon sent him back to me for a scleral lens fitting. There is the eye after his transepithelial PRK. So that haze was a lot deeper, a lot thicker before, but that just gives you, again, an idea of, well, number one, how devastating a Pseudomonas infection can be, but also the depth of the haze involved. This slide is just to highlight how irregular his cornea was. So this is a Placido disc-based system. You can see here that it thinks the pupil is all the way over here, and just to give you an idea of the irregularity. Now, here are his pentacam maps as well. So really quite flat here, very steeper around here, but again, it's not picking up much information at all, just because of how bad the cornea was. This is the scan of the that we had taken with the E.S.P. You can, just one quick thing I want to highlight here is that these lines are supposed to be superimposed over these dots here, the Purkinje images, but again, they're completely displaced because of how irregular the cornea was. I wasn't too concerned about that because this is the area that I am interested in. We can see here, again, it was picking up that the cornea was very irregular. That was quite similar to the other topography that we had seen, but again, not too worried about this. This is what I'm interested in. Look at how highly toric this sclera is, a high amount of withdrawal toricity. And I knew that I put in a chord length here. You can see the difference between the max and the min sag. And so I knew that this is going to be, at the very least, a very toric lens fit. If I had attempted this back in 7 years ago when I first started fitting lenses, it would have been multiple lenses, and it would have been ages till you got your endpoint, if you got to a decent endpoint. But now, armed with this information, I know what to expect. I know where the lens is going to rotate towards, and you're reducing chair time massively. So the first lens fit algorithm, you can choose your suppliers. E.S.P are lab agnostic, I suppose, so they can go with any sort of, they work with multiple labs. So you choose your lab from the drop-down menu, you choose the type of lens, choose your diameter, how much apical clearance you want, how much clearance you want in mid-periphery. You can decide if it's going to be quad specific, etc. The possibilities are endless, and they have anything that you can really imagine, they have it in their database. And again, constantly working with new labs, so they're always updating their databases. So this is what it spits out essentially. Gives you the sag, base curve, and you can see here flat 3, steep 7. So really highly toric fit. So the final lens, he got down to 6/9 vision, which is incredible considering that he was told a PKP was his only option. So we have the sag of both lenses are absolutely bang on. Base curve is the same. Flat 3, steep 7, I went for flat 2, steep 9 after a little bit of settling. So, I mean, that was after, I think, maybe 6 to 8 weeks. And we know that the lenses will settle. They do about 80% of their settling kind of in the first 4 weeks or so. So, I mean, you're not a million miles off. It was one lens change, whereas before I couldn't tell you how many lens changes I would have gone through with that. So, great success with that patient. And that's the lens on the eye there. I think that was actually just before the final bits that I had made, the final modifications that I'd made in there. That there's the landing zone there. Again, that I think I'd flattened that another little bit, but that's more or less 50%, but a little bit flatter. The second case, so it's not another scleral lens case. It's a hybrid case, a hybrid lens. So I use the E.S.P for an awful lot more than just scleral lens fitting, because it is a really versatile piece of equipment. So this is a keratoconic, a male, 39 years old. He's a long-standing keratoconic, but he was intolerant to GP lenses. I had discussed the scleral lens fit with him, but he was, I suppose, cost conscious, and he wanted to see if there is anything more comfortable than an RGP, not as expensive as a scleral. So we went with the hybrid. His left eye is amblyopic, so we decided just to fit the right. So here is his pentacam of the right eye. So you can see he's quite steep, and then left eye, a way more advanced cone, much steeper, and taking up a much larger area of the cornea as well. Looking at that scan, a hybrid might not have even worked, to be perfectly honest. So again, you're back to your fitting sets really, and where do we start? This is what you get. Start here, and multiple lenses on the eye, and I would use anesthetic with my patients to make it comfortable. But, there is a lot of back and forth, and bubbles getting in under lenses, etc., and things like that. The more lenses you're putting on the eye, I suppose, the easier it is for the patient to get frustrated. So that's why the E.S.P is excellent. So I use a cord length of 8.5 because that's the optical zone diameter of the hybrid lens that I was using, and it's great because it'll give me my sag height, and that will translate into what's the first lens that I put on eye. So you can see again here, you put in your details, what clearance you want, and the E.S.P will give you out your lens. So start off with it's suggesting a vault of 350. So as opposed to starting at the 250, you would have put a lens on eye, you would have seen that it was too flat, you would have gone up. And again, you're looking at maybe 3 or 4 lenses before possibly finding your right one. You never really know, but then with the E.S.P, it gives you it gives you that sagittal height, gives you the vault, gives you the information. And it was perfect. So the final lens that I put on was a 350. So the sag was perfect. The skirt value, I would tend to always go with a medium skirt for hybrid lenses, and then adjust it afterwards if I need to. But my go-to on the skirts, the skirt angle is always a medium. So he was very, very happy, and I think I have a picture here. Yeah, so that's the fit of the lens, and that's after a month. So he's well established. We have a perfect vault here, and then over here in the transition zone, you can see good space there. So essential that we have that space there for tier exchange. But now moving on to the last case, ortho K. So scleral lenses, hybrid lenses, now onto ortho K, all done with the E.S.P. So this patient is 9 years old. I'm sure this is quite a familiar story to most people now, being proactive in our management of myopic patients. So both parents are myopic, prescription increasing on a 6-monthly basis, loves to read, loves to hold the book right up close as well. Normal BV, and her refraction there -350 with a little bit of astigmatism, and then -3. And her axial length is 24.6. So this is something that we'll be monitoring at each visit. And that is a printout of the biometer that we'd use. Here's her topography. Again, looks nice and regular. Look at eccentricity values, and that's important when you're fitting ortho K. And so the E.S.P on their algorithm has the Paragon CRT lens, and this isn't a lens that I'm using at the moment, but it is something that I will start using in the future, because of being able to manipulate the optical zone size, and we know that that's important in myopia control. But I use the DRL lens, and it's based on the same principle, and that's where you're matching the sag of the cornea to designing the sag of the lens. So you're looking at the sag of the reverse curve, which is here, and then the sag of the alignment curve. So what I will do is take your measurement on the E.S.P, you put in a sag of, or sorry, chord length of 8 millimeters, and that's going to line up with the reverse curve. You get the sag. You do it again at a chord of 10. You get the sag again, and then using that information, you can design an ortho K lens. This is a follow-up, and we can see that we have an effective power of about a -3, which closely follows the initial prescription. This was in the evening time. This is about a week after initial lens, where you can see here on the tangential curvature map that things are slightly decentered down and temporally. It is early days, so I won't be making any adjustments to the fit just yet, but when the patient comes back in a month's time, if I still see this kind of decentration here, I'll probably increase the diameter of the lens. And again, the axial curvature difference map, you can see that the flattened central profile. So in conclusion, we need to use technology to our advantage. It reduces chair time. It gives more confidence for yourself, so you know what to expect when you're putting lenses on eyes. It gives you patient confidence in you, because you'll definitely exude that confidence when you know what's going on. The E.S.P isn't a one-trick pony. It's not just for scleral lenses. It can be used for a whole host of specialty lens fitting. Again, like I said, I use it every day for my ortho Ks, all my ortho K fits, obviously all my scleral lens fits, and I'll use it for my hybrids too. And I suppose an important point as well is that this is something that's always stuck in my head, is that if you're not innovating, you're stagnant, and if you're stagnant, you're not going to be around, or you're not going to survive for a long time. Your days would be limited. And also to, I suppose, to keep things interesting for yourself, it's important to engage with technology, and for your patients as well, so that they can see that you're keeping up to date with things. And the ESP is just a great great device for that. And finally, one thing that I wanted to say was just, Afe van der Warp, he's saying that millimeters and diopters are a thing of the past, and it's going to be all SAG is the future, and the ESP, they're specialists in SAG. So listen, thanks very much for attending again, and yeah, all the best.